Hi, everyone. Welcome back to another episode of Beyond the Script. Today we have Dr. Paul Zalzal. He is a licensed orthopedic surgeon with more than 20 years of clinical experience. He is actively involved in medical education, clinical research, and basic scientific research, and he is a member of the Royal College of Physicians and Surgeons of Canada. He's here with us today. Thank you so much for coming in.
Oh, thank you so much for having me. My bio makes me sound really boring, so hopefully people don't find me actually that boring.
I don't think so. I think it'll be great. I'd like to just start off by asking, what made you choose orthopedic surgery?
I don't know if you remember a show. It was called, some of your listeners or viewers might, it was called The $6 Million Man. And it was about this guy, and he was in an accident. He was an astronaut, and he was banged up real badly. And so the doctors then put in like a mechanical arm, mechanical leg, and a mechanical eye, or two mechanical legs and a mechanical eye. But you couldn't see them. They looked human. Okay. And they were like super powerful. And so then I think at a young age, I loved the interface between machine and human being. Okay. So orthopedics is basically implanting simple machines in people, right?
Wow.
Plus I studied engineering before medicine, and so this was kind of a natural progression in my mind.
Yeah, it made sense. That's cool.
At the time, yeah.
That's a cool way of saying it. It's like orthopedics is putting kind of machines in people. I didn't think of it that way.
Yep, they're simple machines. A hip is like a ball and socket. A knee joint is like a hinge. And I learned about all that stuff in engineering. And then when I was in medicine, I was like, well, this is the thing that makes the most sense to me in engineering perspective.
Very cool. So I feel like people might have a different understanding of what orthopedic surgeons actually do. So can you take me through a typical day for you?
Sure. Well, every day is different. That's the one thing I love about my job is I'm not in the OR every day of the week. I couldn't handle that. I'm not in the office every day of the week. I couldn't handle that. It's a real mix. So like one day I'll be in the office, where I'm seeing patients, new consults. I do about a day and a half of that. And then I have half a day in the fracture clinic where I see people who've been injured, broken bones, torn ligaments, that kind of stuff. I'm in the OR about a day and a half a week. And then the sort of fun stuff I do, that stuff's fun to me, but the other fun stuff I do is I'm a content creator. So we make videos on YouTube and other social media platforms, and I do some research. And I'm also a co-owner of a startup company, so we develop some medical technology too. So that kind of carries me out through the rest of the week. So a little bit of everything. So I don't have a typical day, but my typical week is mixed with a bunch of fun stuff.
Sure. That's so cool. Well, you're very busy clearly, so it's awesome that you came in. I'd like to ask you just kind of basic stuff about orthopedics.
Okay.
What's the most common injury that people think is really serious but actually isn't?
I would say a meniscal tear. Okay. So someone will come in and say, I have a meniscal tear because they've seen it on MRI. And, meniscal tears can be degenerative tears that are seen on an MRI, or they can be a traumatic tear. But most commonly, the meniscal tear is a sort of a degenerative tear that's not really causing the symptoms that you think it's causing.
Okay.
So I think people sort of hang their hat on a meniscal tear when really that's an injury that isn't as big a deal as they think it is.
Okay, so is the recovery not as intense?
Well, I guess it depends on, so if you're let's say you're a 21-year-old basketball player and you jump up, twist your knee, and you get a meniscal tear, that's a significant injury, right? But that's not the most common meniscal tear we see. The most common meniscal tear I see in my office is someone who's had something going on with their knee, maybe some arthritis, and then they get an MRI, and then the radiologist will, sees the little tear and has to comment on it. He'll say, there's a possibility that there's a tiny little tear maybe in the back of the medial meniscus, possibly. And then that gets amplified, and that turns into, I have a meniscal tear. And so really it's not a clinical entity. It's more of a radiologic finding. So I would say that, that's the entity. So recovery of it, if it's not really causing any symptoms, there's no recovery for it.
Okay, yeah.
But those like meniscal tears that are, significant, those, depending on if you have it repaired or debrided, the recovery can be from weeks to many months.
Okay. So on the flip side, what's something that people ignore that maybe they shouldn't and is more dangerous than they actually think?
Oh, okay. I would say, but not always more dangerous than they think, but Achilles tendonitis.
Okay.
Okay, so that's where you get some pain in your Achilles tendon there behind your ankle, and you kind of ignore it and press through it. And why would I say that? I would say that now because we're seeing a incredible rise in pickleball. Have you ever played pickleball?
Yes, I play it a lot.
Right?
Yeah.
Like 10 years ago, nobody played pickleball.
Everyone loves it.
Right
Yeah.
now, it's so common. And Achilles tendon ruptures, we're seeing that quite a bit in people who like, well, I'm going to go play pickleball for the first time in my life and then lunge for the ball. So if you have a bit of Achilles tendonitis before, where your Achilles tendon is sore, that tendon's a little bit inflamed and a little bit fragile. And if you just kind of ignore it and then press on through, you could end up with an Achilles tendon rupture, which is going to take you a long time to recover from.
Interesting. So is there like a certain demographic you see? Because I know pickleball has been big in kind of the older adults.
Yes. That would be the demographic.
Okay.
If you said it so kindly. But yeah, well, the other demographic, we call them are weekend warriors.
Okay.
So you're basically not doing much during the week. You don't go to the gym. You don't do a lot of exercise. You're just, you haven't done something in a long time. Then all of a sudden it's the weekend. Hey, we need another player on our softball team.
Yes.
Or, hey, I'm going to try pickleball this weekend. You're a weekend warrior, and you go out there and hurt yourself that way.
And like you said, people who maybe haven't exercised in 10 years or something.
Yeah.
I know pickleball has really done that for a lot of people in that older adult community. It's gotten what's been getting them out kind of, which is great, but also I guess comes with that.
However, the Achilles tendon rupture in those sudden lunging sports, we do see that in young people as well.
Okay.
Yeah, definitely people in their 20s and 30s are also getting that.
Is there a habit that people in their 20s, 30s, or really anyone, like a daily habit that people are doing that it's kind of quietly hurting them or hurting their joints?
Yeah, quietly hurting their joints. I would say what we're doing right now, prolonged sitting. If you sit for a long time, let's say you have a job and you're like, okay, I'm at a computer and I sit there all day, or the weekend and you're just like totally sedentary.
Yeah.
Prolonged sitting, I think, is one of those quiet things that does damage your joints because you lose muscle mass when you prolong sitting. You become weak around your joints, and then when you get up and try and do stuff, they'll ache, they will hurt.
Yeah.
Right?
Yeah.
I mean, it happens to me. If I'm sitting at the computer for too long, then I get up to go somewhere, I'm like, oh boy, everything hurts.
Yeah.
So I would say that something that people are quietly doing that's hurting their joints would be just prolonged sitting.
Yeah. So what would you say for people who work like a 9 to 5, how frequently should they be getting up to move their body?
That's a good question, and everybody's different.
Yeah.
And depends what you do in the rest of your day. But I would say, if you could get up once every hour, for at least 5-10 minutes, walk around, change to a standing desk, or do something to move around, then you'll help yourself a lot more than you think.
Yeah, that's really good advice, and that's something I should keep in mind as well for when I'm in the office.
Right?
Yeah.
It's hard to do, but and you look kind of funny. You're like, why is Ivy Catherine walking around the office like that? Well, she's just trying.
I'm getting my 10,000 steps in. That's what I'm doing.
Yeah.
Is there something that people do kind of, I imagine you see quite a bit of athletes or just people who are generally active. Is there something people do in the gym that kind of makes you worry?
Yeah, you know what? There are lots of things, or I think the most common thing I would think it would be lifting too heavy a weight with bad form.
Yeah.
That's a really nasty combination. And because then you can do some damage there, right? Bad form with low weight can do damage, and you give a high weight on top of that, and you can really put some irregular loads on parts of your body that shouldn't see that kind of load.
Yeah. So it's people who kind of are jumping the gun a little bit and wanting to build muscle maybe quickly, but they do it too quickly and too soon. Just do it unsafely.
Kind of the ego weight that you put on rather than the actual weight that you should be putting on. So I would say, if I see someone in the gym with you could tell that's too heavy weight for them and their form is horrible. And often when you increase the weight so much, your form goes out the window anyways.
Right, yeah.
And so that's where I think you can hurt yourself.
Is that something you see? Do you have to tell patients to not do that as much?
If I have a patient that is, that I'm trying to encourage to get into the gym, and I know they haven't been in the gym in many years or ever, then I'll always encourage them just to get a personal trainer first. Like get someone, or even, your physical therapist, physiotherapist, talk to them first and have them show you how to do some of the basic exercises and focus on form. I think that goes a long way. That's what I recommend.
What is a really common injury from people who are overdoing it?
Well, I think the most common injuries we see from people overdoing would be like tendinitis.
Yeah.
You see it in the rotator cuff tendinitis, patellar tendinitis, Achilles tendinitis that we talked about. Those and kind of like the epicondylitis, like the golfer's elbow, tennis elbow. Those are the most common, I think, overuse ones.
Golfer's elbow and tennis elbow, you said?
Yeah, they're kind of like a tendinitis-ish. The kind of an inflammation where the tendons insert. And those, they can come on. You don't realize it. You're doing the same exercise or same sport or whatever. And then all of a sudden you start feeling this pain, but then they can take a long time to go away. And every time you try and go back to your sport or your activity, it's like, I came back again.
Yeah.
So and those are very common.
Yeah. Is there like one exercise that if you could ban forever, you would?
Yeah. In the gym, I think the deadlift.
Yeah?
Yes, I'm not a big fan of that because one, you really have to pay attention to your form, right? Yeah. You keep your back straight and keep the weight very, very close to your body, and then don't jerk the weight when you try and go up. So I think that's an easy one to mess up. It's an easy one to try and put too much weight on there, and I think that one can hurt you, hurt your back pretty significantly in other parts of your body.
I know there's you said something about kind of like the ego weightlifting kind of thing. And I'm curious to know if, since, males have more of a pressure to look more muscular and built, do you see more males than females, or is that?
I've never really taken a survey per se, but I mean, I think so. I would say that's probably true, yeah.
I'd like to ask you some kind of myth-busting questions.
Sure.
Do knees actually wear out over time, or is that a myth?
Okay, so that in our medical world, that question, is this arthritis or is this natural aging of the knee?
Right.
And there's been a lot of research to look into that. No, arthritis is different than aging of the knee. So arthritis is a process that is very different than natural aging of the knee. Knees age just like your skin does and your other tissues. But I have a lot of elderly patients with, really good knees that function really well.
Yeah.
Knees respond well to regular load and regular movement. They don't do so well with injury or, abnormal prolonged loads. So do they wear out? I would say naturally, no, they don't wear out. However, if you've had an injury or something to that knee, then it will start to wear out. It can start to wear out.
Okay. If someone has a pretty severe knee injury, is that the kind of joint, I guess, that will probably not ever really be the same again? Or can they make a full recovery?
You can make a full recovery, okay. However, down the road, I think that depending on what that injury was, it may, let's say you have, you're in your later in life and you've got arthritis in one of your knees and not the other. And you're like, well, that's weird. Why did I only get in one knee? Then you think back, oh, yeah, there's that ACL tear I had in, high school football or the tibial plateau fracture. So there are some injuries to the knee that you recover. You can go back to your sport and do great. But then later in life, you're like, oh, boy, why did I get arthritis on one side and not the other? And you're like, oh, yeah, that was the side I injured when I was younger.
Right.
So I see that a lot.
Okay.
And I tell people that. If I see someone with an acute injury, I'll say, we're going to recover from this. And not just the knee, like any joint, especially around the wrist fractures and things. I'll say, hey, everything, is healed. Everything looks great. But later in life, I'm talking 10, 20, 30 years from now, you might get arthritis in that joint, whereas you're not going to get it on the other side. Yeah. And this is why.
Wow, interesting. So, okay, next one. This one I have to ask for my mom because as a kid, she always got mad at me and my brothers if we cracked our knuckles. And I have to know, is that actually bad for you, or was she right in that?
Or was she saying it just because she didn't like the sound?
It might have been that too. I don't know.
So we don't have any good objective evidence that says cracking your knuckles is bad for you. Really, when you crack your knuckles, you're basically, your joints are bathed in synovial fluid, in that fluid there are gases, nitrogen, oxygen, carbon dioxide. And then when you crack your knuckles, you kind of distend that joint, make the volume bigger so the pressure goes down so those gases come out of solution in little bubbles, and that's called cavitation, and that we think is related to that cracking sound. So really, we don't have any evidence to say it's bad for you. We do know it's annoying to the people around you, though.
Yes, yeah. Yeah, that's the thing. People, like, hate the sound. I wonder what it is about that.
Yeah.
But
I don't know. It's never really bothered me too much, but I've never been around people who, like, crack their knuckles a lot.
What is the biggest misconception you hear about back pain? Because I feel like that's a pretty common one.
Back pain is super common. I would say more people than not at some point in their life experience back pain. To the point where it's almost physiologic. It's almost not a disorder in some cases. So I would say the most common misconception is that people who have back pain think, oh, I really have something wrong with my back. Whereas that most of the time back pain is not a serious problem, extremely common. Sometimes it does represent. There's some red flags, like fever, chills associated with it, recent trauma, new onset. Back pain is not going away. There's certain things that are red flags that can mean something bad is going on, like a fracture or an infection or a tumor or something. But those are super duper rare compared to the vast majority of people who have back pain, which is really just nothing seriously, structurally, mechanically wrong with you.
Okay. So it's more so maybe some people maybe just have to kind of do back strengthening exercises or stretch more consistently or whatever. Yeah. Some lifestyle changes that can help that back pain, and movement, motion is key there that you touched on. Yeah. This just came to mind. Is back pain associated with scoliosis?
Most of the time, scoliosis is asymptomatic.
Okay.
Yeah, so scoliosis is a curvature in the spine, and the vast majority of the time it's asymptomatic. You don't feel anything. And that's kind of the idiopathic scoliosis that you'd see in a younger person. You can have a degenerative scoliosis later in life, but you would probably have back pain secondary to the degenerative process rather than the scoliosis. Once scoliosis gets very severe, which is very rare, but if it gets up to over 60 degrees or something like that, then you can have some symptoms. But the vast majority of the time, scoliosis is asymptomatic. You don't feel it.
Okay, so it's not something people really need to be too worried about.
No. And that's usually picked up on screening. If you have a bad correction and you're still in your growing years, it can progress. So that might need some treatment to prevent it from progressing too much. But then later in life, if you've got a stable scoliosis, usually that's not going to bother you.
Okay. I might ask just because I personally have scoliosis. I was just curious. And I do have back pain, so that was just a personal question.
Oh, no problem. I'll take your OHIP number later.
Okay, great. Thank you. Yeah, fair enough. When it comes to recovery, which is better if there is one, rest or movement?
Movement.
Yeah?
Yes, I would say motion is lotion, movement is medicine, yes. I mean, your initial inclination is to rest. And sure, if you hurt yourself, the first thing you're going to do is rest. But prolonged rest is a bad idea.
Yeah.
Get up, get moving as quickly as possible is the best thing for it. Joints love motion because that's what they're designed to do. They're designed to move. They love motion. Controlled motion with physiologic loads, not abnormal motion and dangerous loads. So I would say movement is way better than rest for many injuries. And there was it just came to mind. That's not a new concept. Salter, Dr. Salter from U of T years ago developed something called the CPM, the continuous passive machine. And he used it in people with knee injuries that just continuously passively moved your knee for you.
Wow.
Yeah, the CPM. It was very popular a few decades ago. But I think we've kind of taken that knowledge and translated it into sort of physiotherapy and you actively moving that joint. But motion of a joint, we've known that is good for you for decades.
Okay.
Yeah.
Wow. I thought maybe rest, but I guess that's you want to get your body, I guess, back into its normal what it's been used to doing, the routine.
Yeah, motion's good. Now, if you have a fracture, obviously we'll put you in a cast or something till the bone heals. But as quickly as we can, we'll try and get you moving again. Prolonged rest is dangerous.
Yes.
Right? You can end up, if you just rest too long, too much, you can end up with a blood clot, you know, a DVT in your blood clot in your leg, which isn't a big deal. But if a piece breaks off and goes to your lungs, that's a pulmonary embolism, and that can be fatal. So prolonged rest isn't good. Right?
Yeah. I hear people say kind of like, what's the worst thing you can do to your body? And the answer is nothing.
That's
if you do nothing,
you're right.
In a way.
And there's been studies where like these, I'm talking 20, 30 years ago, where they took healthy young volunteers and put them in bed and said, okay, you're not going to get out of bed for, 2 weeks. I can't remember how long the study was. But what they noticed was after the study was over and they checked these study participants, they had very measurable muscle loss, very measurable bone loss, and abnormalities in their blood and stuff. So you really can do damage with prolonged rest. Even
just after 2 weeks.
Oh, yeah. Less than 2 weeks, yes.
Wow, you really noticed a difference.
Yeah, you'll know there's a measurable difference, I'd say, after like 2 days of bed rest.
Yeah. I guess that's why, like, when people get casts or on their arms or legs and they get it off, their leg is usually so much smaller.
Right. That's called atrophy. The muscle's just sort of gone away. And muscle atrophy happens fast, but then trying to build that muscle back up again, that can take a long time.
Yeah.
So avoiding it as much as possible. Yeah. But that's a good observation. You do see that, and you see some muscle loss, and then on X-ray we'll see, we call it osteopenia. We call it disuse osteopenia, which is just that disuse. This bone wasn't used. Osteopenia is bone going away. So because we haven't used it, we see the bone going away.
Wow.
Yeah.
Wow, that's scary that it can happen so quickly.
Oh, yeah, we see it all the time on X-ray, disuse osteopenia.
I'd like to kind of go into some storytelling if you have any.
Sure.
Do you have a patient case that really stuck with you that you won't forget?
Can I include ones I've seen on the Pitt?
Yes. Yeah, please.
I have a lot of my own, but I love that show. Oh
what do you okay, I've just the season finale came out last night.
Yes.
I haven't gone to watch it.
Okay, I won't spoil it for you.
Okay,
then.
yeah, don't tell me. But tell me about your thoughts on it.
Oh, it's a great show. I think it's super accurate. I mean, there's a few little things in there that I would say are not totally accurate. But those are ones where I have to like rewind. What did he say? What did he say? No, that's wrong.
Yeah.
But that's very rare. It's super accurate, in my opinion. I mean, super accurate in the sense that the diagnoses are realistic, and the treatments proposed are realistic. It's not so I don't think any emerged shift is that exciting.
Sure.
To be honest, certainly not. In our neck of the woods.
Yeah.
Maybe in some hospitals in the inner city where they get a lot more action, possibly. That go. But the cases are cool and they're really, and it reminds me a lot of ER. I don't know if you remember the show ER.
I know of it. I never watched it.
That was the show when I was going through med school.
Okay.
Right. So, and it was I think it's the same creators and Noah Wiley.
Yeah. No. Yeah.
And I used to watch that show at that time too. I used to learn. I'm learning something. I'm watching. Oh man, I'm learning about stuff while watching ER when I didn't know much stuff.
Right.
So I think that's great. I love that. There's a really cool case of necrotizing fasciitis that I always remember. A woman came in with a little bit of redness in her leg, and then it turned into necrotizing fasciitis, which is known as flesh-eating disease. That kind of thing. Yeah, necrotizing. So that was a really cool case that they showed.
Yeah.
My own cases. I've had some that are memorable, some devastating ones. There's one that's stuck with me all my life and I won't go into too much detail about it, but when I was a resident doing my ICU rotation, there's a young man who was in a personal aircraft.
Okay.
I don't know what kind of aircraft, some real personal lightweight aircraft, not quite a plane, but anyways, it caught fire, and so did he, and he got burns. Full thickness burns over 70 or 80% of his body. Yeah, and he he was a young guy with a wife, and then his wife and young daughter came in, and so that stuck with me for a lot of reasons. But I've had a lot of other cool, interesting cases. I remember I was a weekend warrior myself.
Oh, yeah?
Playing soccer on the field and recognizing that weekend warriors get injuries, so I would not leave a 1 meter circle. If the ball came near me, I'll kick it. If it doesn't, I won't.
Okay.
But then there were some other players that were a lot more ambitious, and one woman was just doing great. She was running all over, and she just lunged once and went down and went over and looked at her. And it was the first time I'd seen an Achilles tendon rupture, like within 4 seconds of it happening.
Oh my gosh.
Because I usually see them, the next day or
Yeah.
after they've gone through emerge, then been referred to our clinic. So it's kind of cool to examine that and see that before all the swelling and all the inflammation happened. So that was an interesting case.
Yeah, and lucky that you were there, I guess.
Yeah, we got her to the hospital, got her splinted
Yeah.
right away, and then followed her up in my clinic. And,
Yeah.
Yeah.
Just when you were talking about the burn patient, it just made me think about that's I can't imagine seeing something like that in real life, because the only thing I would see from that is a TV show. It's obviously fake. It's obviously dramatized. Seeing that in real life and seeing their wife and child come in, actually witnessing that real human moment. Of course, that would stick with you.
Are you trying to make me the first doctor to cry on
No,
your show?
I'm so sorry. No.
I'm just kidding.
Fair enough, though.
It was.
So,
And
thank you for sharing.
No, it was tough. It was tough for all those reasons. Just like you said, it was very real. The daughter went to the bedside to sing to her dad. And, we all knew because of the percentage of burns that he had that he was not going to survive. And the thing with burns is, I'm not a burn doctor, I'm not a plastic surgeon that deals with that stuff, but I know that, you don't die immediately. Like, you're awake, alert, and it happens, gradually, just from fluid loss and metabolic changes that happens when you lose that much skin. Yeah. I think they had one of those on the Pitt as well, actually.
Oh, did they?
Yes, there was a case of that on the Pitt too. And as soon as I saw it, I was like, oh boy, that took me right back to my ICU training. So those are tough cases. Yeah. It's
cool that you, watching the Pitt, or any medical show, you have the perspective that very few, a very small percentage of people watching that would know. If they say, I want, order me 10 cc's of whatever, you know what that means. Yeah. And that's really cool. It is actually cool. It is cool to be able to follow it along from that perspective. But it's hard not to critically appraise it the whole time. Yeah. It's hard not just to sit back and enjoy the entertainment. You're bet, always oh, why did you do that? Oh, is that right? Oh, is that what you do? And I'll be Googling it, wait, no, that's not that's so. And a lot of stuff's newer, too. Where I'm like, well, that's not the way we used to do it. Because I don't work a ton in ER or anything like that anymore, but I did in my training. Yeah. So it kind of, it's a different watching experience when I'm looking at my family watching it. I bet. We're watching it from different perspectives. Yeah. You're right. That's a good point. Whereas I watch it, I'm like, I'm sure that was the right diagnosis. And I'm sure that was correct. Yeah. They usually are. Yeah. Is there a worst injury, an orthopedic injury, I guess, that you've seen? A worse orthopedic injury that I've seen? There's, I guess worse depends on, how bad is it acutely or how much is it going to change this person's life, or are they going to lose a limb from it? So we've seen all those different kinds of injuries, but I think for me, one of the worst ones that stuck with me was, again, it was many years ago, just when trampolines were becoming popular in the backyards. Yeah. And there was a teenager, and she was on with her dad, and they were doing that thing, where you super... I know exactly what you mean. It's called, but they're both on it, and then if you hit it right, you can send someone flying. Yes. But I guess they didn't hit it quite right. So the dad went down, and as he was coming, the trampoline was coming up, she was coming down. Okay. So her ankle saw way more than her body weight, right? Because it saw if you just jump on a trampoline, it's kind of always your body weight, but this thing was coming up at a lot more force than if she was jumping on it. And it injured her talus in her ankle. A talus is a bone in your ankle that is mostly covered with cartilage, so it doesn't have a lot of blood supply. So damage to the talus doesn't always heal well, and that bone can eventually die. And we could see with the amount of damage to her talus, it was going to go that way for her. And she's a teenager, right? And so we knew that down the road, this is going to mean a fused portion of her foot would need a fusion, and maybe eventually, the ankle fusion. And so that was, in that millisecond, that was a life-changing,
right? Because
That's
now
terrifying.
if you're a teenager, that changes what sports you're going to do. That changes that might change what job you're going to have. Changes where you're going to walk for the rest of your life. So when you say worse injury, in my mind, that's the one that comes to mind
For
first.
sure. Is there a most avoidable surgery that you end up performing?
I would say there is less so now, but, over my career, I've seen this done where it's probably avoidable, would be arthroscopy of the knee. Arthroscopy of the knee. We used to do a lot of that, 10, 20 years ago for just to treat some arthritis. You might have heard people say, oh, I had my knee scraped or cleaned out. Then there was a study that came out in the early 2000s that said, hey, if you scope a knee that has some arthritis in it and you're scoping it for arthritis, it's they don't end up doing better after 2 years. They're not feeling any better than if you didn't scope it. So then we kind of learned that that's not a great indication. But that took a while to get into clinical practice. So I think for many years we scoped a lot of knees that nowadays we don't scope as much.
Okay.
So you say there's a surgery that was avoidable. I would say arthroscopy of the knee is the first one that comes to mind. Fortunately, we've changed our practice now so that we're not doing that as much without the right indication, but that would be one. Do
you feel like patients, are they generally, if you can tell a difference, are they generally more eager to just say let's just do the surgery so I can get this, so I can have this done and be healed, or are they more avoidant towards surgery?
I'd say both.
Yeah.
I mean, I have some patients who are just do it right away, jump into it, let's go. And that's where a longer wait list is sometimes helpful, because I'll say, okay, let's put you on the list. All right, and let's see how you do. And then lo and behold, they'll go and lose weight, join a gym, get active, change their diet, change their lifestyle, and they come back and you know what, I'm going to postpone that.
Yeah.
I'm like, well, you waited a year and a half, you want to postpone it? And they're like, yeah. So those people, sometimes might have thought of jumping into surgery too soon, but fortunately our wait lists kind of buffer that.
Right.
But then I do have other people where I'm like, I really think, and I never tell someone you need a knee replacement or you need a hip replacement or you need this. Very rarely do I tell them that. For elective stuff, for trauma stuff, no, but for elective stuff. And I'll be in my mind, I'm like, I really think this could help this person. But for some reason, they're like, I don't want to do it now. You know what I mean? My friend had a really bad experience or whatever, and they're like, no, I'm going to put it off. I'm like, okay, man, that's fine. But in my mind, I'm like, I know you'll be happy once you have it done. Or there's a good chance you'll be happy once you have it done.
Yeah, fair enough. And I'm sure you see both.
You see both sides.
Yeah.
Yeah.
Is there something that patients Google that you wish they wouldn't?
I'm okay with people Googling it, but I wish they wouldn't believe everything they see.
Right.
So I think it's great to Google, and I think that's important because I always say you are in charge of your own health, and you have to know about your conditions, you have to know about your treatments, and there's so much good information out there now to get. But there's bad information too. So don't believe everything you see, and try and approach it with a critical lens when you do see something. And there's different tools you can use to try and critically appraise something, but I tell people that the simplest way to do it is just to ask yourself, what is this thing I'm reading or what is this thing I'm watching? Is it an advertisement? Is it entertainment? Or is it medical information? Now, the content that we create is a little bit of entertainment and medical information, I say, but basically the main idea of what you're reading, watching, what you're consuming. Is this an advertisement? So they're going to talk about something, then at the end of it they're going to say, here's the supplement to cure it.
Right, yes.
Then you're like, okay, maybe take that with a grain of salt.
Yeah.
Or is it just entertainment? Is it just someone on TikTok just trying to get some views or entertain you? Maybe that's not good medical information. Or is it real medical information from an expert in the field?
Right.
I'm like, okay. And they're not standing to gain anything from it. They're just sharing some medical information with you. And if you can ask that question when you Google something, then I think your Googling will be useful.
Yes.
If you just blindly believe everything you see, then your Googling can send you down the wrong path.
Right. And speaking of content creation, people who are just sharing, medical information just to help educate. For those of you who don't know, Dr. Paul Zalzal has a YouTube channel, very successful one, with Dr. Brad Weening. They have over 1 million subscribers, and congratulations on that following.
Thank you.
That's so cool. I'd love to know what made you get started and what inspired that idea.
Sure. So yeah, we make content and our channel's Talking with Docs. We started it 10 years ago. We made it for our patients because we recognize that patients forget about 60 to 80% of everything we tell them. And that's not the patient's fault.
Yeah.
It's not the doctor's fault. It's just that medical information is so dense and the body's so complicated. And when we explain something, there's a lot. And now we can't have you come back to our office once a week for 6 weeks to keep explaining it to you, right? So we made these videos to say, okay, everything I just said to you, because I've said this a million times to a bunch of other patients just like you, is on this video. Just go home and watch it. Or if English is your second language, go watch this with your daughter or someone who speaks English, more. Or maybe we see someone whose memory is not great, and just go and watch this with a family member or your caregiver or whatever. Go home, and you guys, this is exactly what we told you. So we made these videos, and then I said to Brad, like, hey, did you give our video to 1,000 people? And he was like, no, I gave it to like 2 people. And I'm like, oh, and then all of a sudden there's 1,000 viewers. And the next week's like, did you tell 5,000 people to watch our video? I'm like, no, I had 10 people in my clinic and I told 3 of them to watch it. So we saw there was an appetite for it.
Yeah.
So then we just kept going with it. And we learned a lot of things along the way. We learned that people need to be reminded more than they need to be taught. Okay. Right? Because a lot of stuff we talk about, people know, but they need to be reminded about it, just like us. We started getting other specialists involved with it. The ortho community is loving this stuff. Let's get a cardiologist on. Let's get an endocrinologist. Let's get a neurologist. And so we got our friends, and said, hey, just come and don't prepare. Don't do a ton of research. Just come and tell us what you tell your patients. Yeah. And that's what people find interesting because that's the way they can prepare before they go see their doc or go see it after they saw their doc. Yeah. And a lot of people, and then we started seeing, well, geez, we're getting viewers from around the world. Yeah. And a lot of people don't have access to healthcare. So then we started seeing, well, a lot of people are coming to watch our videos who can't get to see a doctor. Although our videos don't replace seeing a doctor or a healthcare provider. But it's helpful for people who can't easily access that. Yeah. So that's how we started, and that's how we kept going.
I think it's so cool that you guys take the extra time of your very, very busy weeks to do that, to educate, purely just to educate and help people understand things in simpler terms. And you guys do all sorts of videos, and it's not just ortho. It's so cool.
No, ironically, we're a couple orthopedic surgeons, but our most popular video is one about hemorrhoids. So, okay.
There you go.
We had a general surgeon talking about that. But we have so much fun making these videos, so it doesn't really feel like work. We're just sitting down, the 2 of us. We share an office. We've known each other for decades since we were medical students. And we just have fun doing it, so it doesn't feel like work.
That's awesome. I think it's so cool. I think it's so cool. Are you guys on Instagram and TikTok as well?
Our biggest platform is YouTube.
Yeah.
But we're also on Instagram, TikTok, and other platforms. And we don't have as much uptake on those, but definitely YouTube is our biggest thing. We're on MSN Network. We have someone in the U.S. who's getting our videos on there. And just recently, we are just getting onto the platforms in China. Wow. Yeah, we had someone approach us and said, hey, I have a company that puts videos out in China. Can we repurpose your stuff? And we're like, sure, have at it. So we've been working with them to get into that population as well.
That's awesome.
Yeah.
Before we wrap up, I'd love to do some quick rapid fire questions, just quick kind of one-word answers. Ice or heat?
For vacation, I prefer heat. Although I do like going skiing on vacations. You mean for injury?
Yeah.
Oh, yeah, for injury. Both. I would say ice for acute injury.
Okay.
And for like a chronic tendonitis or chronic injury, heat is probably more helpful.
Stretching before or after workouts?
Both. So
okay, fair enough.
Yeah, stretch before, do a dynamic stretch before, and a static stretch after.
Okay. Running or cycling?
Both. I would say cycling's low impact, so it might be easier for you. However, running does build up bone, and is a bit of impact is good. But if you have some aches and pains, you might find cycling a little bit easier to get your cardio in.
Is there much of a difference between the benefits of walking versus running?
So I think it depends what your goal is. If you're, walking is awesome in terms of motion, and some, keeping your muscle mass up and that. But if you're wanting to improve your cardio output, running's going to be way better than walking for sure. If you're working on your FEV1 or you just really want a good cardio workout, running's going to be walking for sure. But walking you can usually do for a more prolonged period of time, and definitely to keep your mobility and for weight management and for, depending where you walk, for mental health. Nature walks and things like that have been shown to help tremendously for that. So I think they're just different activities, and I would recommend doing both.
Yeah. Last one. What is the most underrated way that someone could prevent an injury?
Strength training. 2 or 3 times a week of actually doing, you don't have to do super intense heavy weights. You can just do a lighter weight, low intensity, lots of reps. But strength training, I think, was the best way you can prevent an injury. And so, let's say I said, okay, I'm going to start playing pickleball. Yeah. Instead of just running to the court, I would take 2 weeks and build up to it. Strengthen my Achilles, strengthen my calf muscles, strengthen lower extremity groups, strengthen my arms, gradually do the training, and then play the sport. And I remember Brad Weening, we talked about him, my office partner and YouTube partner. He'd go on the ski trip every year with a bunch of friends, and for 4 weeks before, he would just start doing a focused muscle strengthening to get ready to go on a ski trip, right? And he always did it with it and came home in one piece. So
that's that's got to be so rare. I think most people go on ski trips. They're like, cool, we're going skiing, and then they go that weekend. But it's so cool that you guys would know the best way to do it.
Build up for it. I haven't skied in 5 years. I'm going to go for a week to Whistler.
Yeah, exactly.
Your odds of injuring yourself go way down if you train a little for it.
Yeah. If there's one thing you wish everyone knew just about protecting their joints, what would it be?
I would say recognizing that motion is important. Immobility is the worst thing you can do for joints. So like you said, walking, just any kind of exercise, keep moving. Joints love to move, right? And so if you can keep your joints moving, that's the best thing you can do for your joints. Yeah.
So that's something, if you could prescribe exercise, you would. Well, I guess you kind of do, but...
Well, we recommend it, but I know in Australia they do they give prescriptions for exercise.
Oh, wow.
The closest thing we do here is a prescription for physiotherapy, and I'll often say exercise-based physiotherapy. So that's how we kind of prescribe physio, but not everyone has coverage for physiotherapy, right? Yeah. So I would just prescribe some sort of exercise. And it doesn't have to be weights. You can use body weight exercises, a walking, if you can get something in for cardio, and if you can, get something in for some strength training, that'd be my prescription. Yeah. And it doesn't have to be every day of the week. We've seen the benefits of strength training. The benefits from doing nothing to 1 or 2 days a week is huge. Wow. Then if you go from 1 or 2 days a week to 4 or 5 days a week, you're still getting benefit, but much less than nothing to 1 or 2 days a week. So it's not that much you have to do. Yeah.
That's a great message, because I think some people might get intimidated by the idea of hearing strength training. They're like, well, I don't really know what to do, or sometimes the gym in general can be intimidating. So for people to know you don't have to go crazy, just anything is better than nothing.
Right. Anything is better than nothing. And the proof is in the pudding. I mean, we have studies that show how well you do how well you can stand up from a chair, how many times you can do it in a certain time, sit to stand test, or how many you can do in a certain time, or how long it takes you to do a certain number, correlates with mortality. Wow. A direct correlation with how long you live. And even more subtle would be grip strength testing. How strong your grip strength is directly correlates with mortality. Wow. So, yeah.
I didn't know that.
Doesn't mean you can crush a beer can better. It means you're going to live longer. Wow. Now, you can't go and just strengthen your grip strength and say, I'm going to live forever, but it just happens to be one of those associations with mortality.
Yeah. And even just, you said sitting to standing.
Sit to stand, yeah. That's a great exercise. Sit in a chair, just sit and stand, sit and stand, sit and stand. See how many you can do in a minute, or see how many you can do to failure. Wow. And that's a lot of muscles you're using just to sit to stand. And guess what? You do that in life a lot. Yeah. So it's going to help you in life.
Yeah.
For elderly people, you know what I mean? Trying to maintain their independence. Maintaining the ability to go from sitting to standing is huge.
Yeah. That's amazing. What a great message. That's so helpful for people to know something as simple as that. Yeah.
It doesn't have to be complicated.
That's awesome. Well, thank you so much again for coming. Again, this is Dr. Paul Zalzal. You can find him on YouTube, Talking with Docs. This was awesome. Thank you so much.
Thank you. So this is great. I love what you guys are doing here, and good luck with
good.
it. This is great service for public to, the more good information we put out there, the better off everyone will be.
Absolutely. All right. Bye, everyone.